Today, I will be wearing two hats, a hat of a moderator and a hat of a speaker, and I will be joined by two of the most celebrated speakers in the field of glaucoma, Professor Keith Barton from Moorfields, London, and Professor Ahmed Mustafa Abdurrahman from Cairo University, two people that I personally have learned a lot from, and I look forward to listening to them. To Keith to speak about the evidence in glaucoma. Keith, can you unmute, please?
Yeah, I'm on. Can you hear me now?
Yes, we can hear you well, Dr. Keith.
Just give me a second to share the screen. It should be coming up now. No. Is Tarek unshared? Because it's not sharing my screen at the moment. Okay, seems to be coming. Thank you. It's unusual when I don't talk about surgery, but it is very important to be aware that for a very long time, we didn't really have any evidence that treatment made any difference to glaucoma. And this may seem surprising in this day and age, but we have been lowering the IOP for decades or probably centuries. But arguably until December 2014, there was really no highest level evidence, that's a tongue twister, that lowering IOP was better than doing nothing, which seems surprising. There was circumstantial evidence that treatment works, but largely circumstantial. This came initially from the Advanced Glaucoma Intervention Study, which was the first study that showed that patients with lower IOPs actually did better. And for those of you who were around in the late 90s and early noughties, you'll be very well aware of this graph because it was shown by every pharmaceutical company in every single meeting, every single day of the year for several years, because at the time it really was the only evidence that, that glaucoma treatment did anything. And it wasn't even a primary outcome of this trial. The trial was a complicated surgical trial. And this was a post-hoc retrospective analysis of the entire group rather than just the individual treatment arms. And it was, we have Paul Pamberg to thank for forcing the Aegis investigators to come up with this graph. But it did show that patients with low pressures did better than those with higher pressures in the normal range. And remember that prior to that, it was believed that if your pressure was 21, less than 21, you were fine, when clearly this is not the case. And in advanced glaucoma, very low IOP seemed to prevent deterioration, even if you started off within what we call the normal range at that point. It wasn't until later in the 90s and in 2002 that a true treatment, no treatment trial came along, the early manifest glaucoma treatment trial. And this still shows, this still is of great relevance today. In fact, I was somewhat taken aback 2 years ago when the American Glaucoma Society invited me to speak in the early manifest glaucoma trial, a trial of which I had nothing to do with, a trial which was non-surgical, and I'm primarily a surgeon, but I asked them why they wanted me to speak, and he said, well, it's a European trial and you're European. So that was the reason. But going through that, this is a very interesting trial. And the objectives were really to evaluate the effectiveness of reducing IOP in early, previously untreated open-angle glaucoma. They had secondary outcomes of objectives of looking at factors related to glaucoma progression and to study the natural history. It was randomized. They managed to get 255 newly diagnosed patients between 50 and 80 years old with early glaucomatous field defects. The interesting thing about it is it's the only trial that was population-based. They screened 44,000 residents of the cities of Malmö and Helsingborg in Sweden. Why was it population-based? Well, it's actually quite a funny story. It's because there weren't enough patients otherwise. But ironically, that made it a much more interesting study simply because population-based. As we know that the majority of glaucoma in the community is actually undiagnosed. And through the study, they actually diagnosed everyone in the community. The recruitment was throughout the 1990s, randomization again throughout the 1990s. They screened 44,000 of the population, found 2,252 glaucomas, 679 of whom were in the eligibility criteria of early manifest, and 255 randomized. Again, you can see why it can be difficult to produce such studies, is that the patients are largely elderly. The pressures were the low 20s, as you might expect. And treatment was rather odd, but presumably that's what Swedish treatment was at the time. It was a combination of betaxolol and argon laser trabeculoplasty, which isn't really, was never really what one would have used as primary treatment in the UK. I'm not sure about anywhere else. If the pressure was more than 25, they added latanoprost in treated eyes, or if it was more than 35 in control eyes. If progression was reached, further clinical management followed usual customary patterns, whatever that happened to be. For most patients, only one eye was eligible baseline, but if the second eye became eligible during the trial, it was also considered for analysis. And it's important to be aware that if you're entering two eyes in a trial, these are not independent events, and you should never do this unless you carry out statistical analysis to wait for the second eye. So they randomized of all these people, 129 in one group and 126 in the other. And these are the demographics. But they lost only 6 patients to follow-up, which is quite spectacular. I think in TVT study, we had roughly 30% loss to follow-up. It's very, very hard to keep losses down. But on average, treatment reduced IOP by 5 millimeters of mercury, or 25% throughout follow-up, which is pretty impressive despite the type of treatment at the time, I must say. And you can see there's a difference between the control arm and the treatment arm in terms of glaucoma progression. Progression was less frequent in treatment arm, still 45% though, than in controls with 62%. And it occurred significantly later in treated patients than in controls. That was a primary outcome paper. Of course, like all good studies, this generated a veritable plethora of further papers, and these went on and on for years, the last one being in 2009, so not that long ago. But overall, patients treated in the EMGT study had half of the progression risk of control patients, and the magnitude of initial IOP reduction was a major factor influencing outcome. And this was the first RCT evidence that immediate IOP lowering treatment delayed progression. IOP was the main risk factor for progression. Exfoliatives progressed quickest and NGGs the slowest. Fluctuation. Now, fluctuation is much talked about. There's a lot of stuff out there about fluctuations. It's almost like whether we should be wearing masks in public, even though there's no hard evidence that fluctuation really makes any difference, independent of actual IOP level. It's still touted over and over and over again. There's no correlation with disc hemorrhage. So why do I say that EMGT was not the highest level evidence? Well, if you're being really, really pedantic, you need a placebo mask study. And I have to congratulate Ted Garway-Heath and his group for the UK glaucoma treatment study, not just because it was the UK study, but it really was the highest level evidence. And they randomized 516 newly diagnosed patients with open-angle glaucoma in 10 centers between 2007 and 2010. And you can see that these were all tertiary referral. They were a mixture of tertiary referral teaching and district hospitals. Patients randomly allocated 1-to-1 and stratified in a permuted block design to receive latanoprost or placebo, so that there were equal numbers of equal spread of randomization throughout the centers. The purpose of a stratification is not to permit sub-analysis later. It's to ensure that you have equal arms, that you have equal numbers of patients in treatment in both treatment groups throughout all of the centers in the multi-center trial. The drops were administered from identical bottles once a day to both eyes. The primary outcome was time to visual field deterioration within 24 months. And analysis were done on all individuals with follow-up data. So the 777 patients assessed, 258 allocated to latanoprost and 258 to placebo. And 231 in the latanoprost group were analyzed and 230 in the placebo group. You can see the study centres here all around England and Scotland, in fact, as well. And the majority actually had a family history of glaucoma, which is interesting. Baseline pressures were low, 19.6 in the latanoprost group, 20.1 in the control group. And at 24 months, the mean reduction was 3.8 in the latanoprost group and 0.9 in the placebo group. But visual field progression was significantly longer in the placebo, significantly longer in the latanoprost group, as we'll see in a moment. The mean deviation in visual field at enrollment was low, 1.6 in the 1.6, 1.4 in the better eye, and 4.4, 4.3 in the worse eye. In this study, they randomized patients, not eyes. There's the mean IOP distribution. Again, it's low to start with. And vast majority of these patients had open angles. And very, very few had exfoliation. So it really was a primary open angle glaucoma study. It's a complicated study. There's the permuted block design that I mentioned. It's completely masked. It's triple masked. So the patient, the doctor, and the person assessing the outcome were all masked to treatment. So not double masked, it's triple masked. They based their visual field outcomes on the early manifest glaucoma treatment study, but they did change it slightly to compensate for quirks in the UK GTS. It was again 3 visual field locations worse than baseline at the 5% level in the 2 consecutive reliable fields. But they then looked at a second consecutive pair of reliable fields where the locations didn't have to be the same as the first. So really very stringent criteria for progression. Time to progression was defined as time from baseline to the 4th visual field confirming progression. So really wasn't background noise here, and really stringent criteria for progression. The primary endpoint was assessed on the day of each visit and then verified by the reading centre. They had a change in primary outcome at the start of the study. The initial plan was to assess at 24 months, but the Independent Data and Safety Monitoring Committee requested an interim analysis and a change based on time to event. So in other words, the initial plan was to analyze everyone at 24 months, but an interim analysis changed this and recommended early termination of the trial so that patients who had an event within 24 months were then censored. But they analyzed both. The IOP graph, now there's 2 IOP graphs. They look pretty obvious, but it actually requires a little of interpretation here. Initially, the graph on the left is the raw IOPs. The graph on the right, which shows the pressure above in the placebo group and the pressure below in the treatment group, as you can see, are slightly higher than the raw data. And these are based on patients who are then censored at an event and their last observation was carried forward. So this is an LOCS, it's called, graph, where the last observation carried forward is the pressure at the end. for patients who were censored within 24 months. And you can see here it's quite clear that, that in relatively short time of 24 months in people with fairly mild glaucoma, not bad glaucoma, there was a significant difference in the number of events on this Kaplan-Meier graph. You can actually see here how the visual fields changed in each event. Most of them were very, very small changes, but it was based over 4 fields. There were very definite changes. And most of them are fairly close to the no change line. Although you can see with some of those with more advanced glaucoma that the change was greater. Though those with mild glaucoma was very little. So again, a salutary lesson to watch out for those with more advanced glaucoma. This is just other adverse events, and there were very few. And these are the serious ones, which were largely myocardial infarction, other surgery, cerebrovascular accident, nothing really due to the glaucoma. So the UK GTS showed that visual field preservation was significantly longer in the latanoprost group than the placebo group. And they noted 18 serious adverse events, none attributable to the study drug. So this was the first randomized placebo-controlled trial to show preservation of the visual field with an IOP-lowering drug in patients with open-angle glaucoma. And the study design enabled significant differences in vision to be assessed in a very short period of time. And this was published in The Lancet in 2015. What's new? Well, we've seen the EAGLE study, which was related to angle closure, but in open-angle glaucoma, the latest is really the LIGHT study, the laser and glaucoma and ocular hypertension treatment study. This study, of which I was a small part, started with a Carlo conversation in roughly 2006, 2007 between myself and Ted Goodwin from Luminous, who was very keen, who was working with Luminous at the time and very keen to sponsor an SLT study. We handed it to Gus Gazard, who at the time an enthusiasm, but it was Ted Garway Heath who came back and said, well, you shouldn't really just do an IOP study here. Every man and his dog is going to do that and it's going to tell us nothing. So Ted turned it into a quality of life study and very, very complex and very rigorous study designs. The LIGHT study, which demonstrated clear benefit of selective laser trabeculectomy over medical therapy in newly diagnosed medication-naive ocular hypertension and glaucoma patients, is the latest, and this was published in The Lancet just last year. The background really is that laser's been around for a long time, and the glaucoma laser trial in 1990 or before showed that really it was a good treatment, but it was never taken up as first-line treatment. It's been very popular in fee-for-service-based environments for treating people who have reached the end of the world in terms of eye drops at a time when it's probably not going to do that much use and people should be having surgery. But it's probably an easy treatment for early patients for whom it had never really been used a lot. Of 718 patients enrolled in this study, it's a really big study, 356 were randomized to SLT and 362 to eye drops. And at 36 months, 74% of the laser group did not require any eye drops to maintain IOP. And eyes of this patient were within target at more than 93%, compared with 91% in the eye drop groups. There really wasn't that much difference between eye drops and laser, but the point was that laser wasn't worse. This study didn't actually show any quality of life difference in the primary outcome. So eye drops and laser for early treatment are equal in terms of quality of life. It simply showed that laser was equally effective as an initial treatment, and most patients didn't need eye drops in the first 36 months. We were actually able to show, in addition, that it was repeatable, and the repeatability study has just been published in ophthalmology. So in conclusion, medical treatment works. Medical treatment delays progression, even in patients with early glaucoma, even with monotherapy in the majority of patients. And the quality of life of laser wasn't any better, although laser was equally effective. And thank you for your attention.
Keith, thank you very much. This was a tour de force, actually, on the evidence in glaucoma therapy.